We're going to start off with Melanie Melanie Bowden as chair of the president of the Craniofacial Society to kick off. So, Melanie, would you like to open up for us?
Absolutely, Tim. So, good evening, everyone. My name's Melanie Bowden, and I'm privileged to be the current president of the Craniofacial Society of Great Britain and Ireland. So, I want to warmly welcome you tonight to our inaugural pre-conference webinar. So, this is the first in a series of 3 webinars jointly hosted and run by our 3 organisations. So, that is the Craniofacial Society, which is a multidisciplinary group of healthcare professionals committed to improving the clinical care of children and adults with cleft lip and palate and other craniofacial anomalies. The second organisation is Cleft, Bridging the Gap, a charity focused on providing permanent, sustainable ways to improve cleft care in both the UK and overseas. And finally, we're collaborating with CLAPA, the Cleft Lip and Palate Association, a national charity supporting people born with a cleft and their families in the UK. So our webinar series aims to provide a platform for us to discuss important topics in cleft care and bring together diverse views and experiences from health professionals and patients and families in the cleft community. So we want it to be very collaborative. This is a really exciting opportunity. We hope it will be relaxed. We hope that everyone will feel able to ask questions and express their views. I'm going to do a plug now. It's only 6 weeks until the Craniofacial Conference. I hope that many of you will be able to attend in Manchester in April. And we hope that this webinar will facilitate connections between us all that can be developed further when we meet in person, hopefully in Manchester. So it's thanks to a few individuals that these webinars have come to fruition. First of all, Brian Summerlad proposed some months ago that it would be very worthwhile and powerful if our 3 organisations come together to work and collaborate in this way. And I think it's been an excellent idea, Brian, and I hope this is the first of many such collaborations. I also want to thank Matt Fell, who came up with the idea of the webinars, after realising we just can't cover all aspects of cleft care in the 3-day in-person conference, and that this would be a practical and cost-effective solution. So thank you, Matt, for coming up with this really good idea. I also want to thank everyone who's been involved in the organisation, behind the scenes, and all the colleagues who've given their time to act as chairs. And so I'll now hand over to the chair for tonight, Mr. Tim Goodacre. Thank you, Tim.
Melanie, thank you very much, and again, thank you for your support and bringing us all together and being so positive about it all. And echoing your thanks to Brian, both Brian and Matt. And Matt has been an absolute tour de force in getting this together. So I'm not going to deliberate much more. We can have some sort of nice thank yous at the end. What we're going to talk about this evening, though, is not so much about our collaboration, but how can something which probably many of us want to address, which is how can we and our team make a real difference? And this should really be a positive difference. We don't want negative differences in low and middle income countries. Welcome to you all, and I'm delighted at the spread of people who are both attending and also our speakers. And thank you to underneath it all to Mel at Cleft for her support as well in all the organisation in the back where nobody sees her. So we've got some very quick fire presentations which are going to take no more than 5 minutes each for each of them. 1 or 2 are pre-recorded. But we do hope that Shankar Rai can come in from Nepal live, but there's a little bit of a problem on that at the moment. This is very much your webinar. And we want to get to the bottom of your questions about how you can help better. So we want the questions that you really want to ask. And there's a lot of underlying philosophy of how best to work in partnership with colleagues overseas. And we are very there's a very distinctive philosophy behind Cleft, which I think Brian is going to address in a moment. So we do need all of your questions and all of your participation. What that means is when we come to the question session at the end of these talks, which we hope will be at least half of our time together, We don't want sermons if that's not too pejorative. But if you can be thinking of formulating what you really want to ask, there is a wealth of experience, both on screen and amongst the speakers that we can plumb into. So without further ado, I'm going to hand over to Brian to introduce Cleft itself. And thank you, Brian. I know you've had enormous problems with IT over the last 24 to 48 hours. So well done overcoming those. And we look forward to your introduction. Thank you. I think you're still muted, Brian, are you? Brian, can you unmute yourself?
You know?
We can, well, yeah, thank you.
Okay, so thank you very much, Tim and Melanie. I'm looking forward to the discussion. We've been given 5 minutes maximum, so this really is a whistle-stop tour. This is the ethos of the charity Cleft, which many of you are involved with and know about. But to summarize it, these are the 5, I would say, principles that in which we believe in Cleft, that we can most help Cleft centers in low and middle income countries. That our links should be as guests, that the ownership of the center is by the local team, that the team should be multidisciplinary, that care should be long-term, that our activity should be aimed towards training, not doing lots of cases, and that what we help to produce in the end is sustainable. And I'm really going to talk more about challenges than possible solutions, and perhaps we can talk more about the solutions in the discussion. So ownership by the local team. It's challenging, and what you really need is a motivated leader who, I would say, often does so at his own personal cost, and that leader has support from his local team. Our most long-standing relationship is with Dhaka, and we're going to hear, I hope, from Papon later, but he has provided that in Dhaka, in Bangladesh. Teams should be multidisciplinary, and that means respect between different members of the team. Recognizing the need that care should be multidisciplinary, and getting away from the idea that the surgeon is God. And that's still a huge problem in many of the countries that I've been to. There's still this view that there's the surgeon and there's everyone else. And this concept that everybody is equal is really difficult to impart. And care should be long-term. And that means that the team needs to understand the need for that long-term care, and that's not part of the tradition of many countries. And there has to be the organization, the follow-up organization, to ensure that those patients can be followed up and seen in the long term. We should be there primarily to train. And therefore, training should be preferably in government or at least training centers, and ideally with links with universities. And this is a problem because of other NGOs, and particularly an NGO who carries out its work in private hospitals and pays surgeons and the hospital to do that work. So this man, I visited in Varanasi in India some years ago. He did 1,800 cleft operations in 1 year for that NGO. I'm not going to mention the name, but you probably know who I'm talking about. Meanwhile, back in the university hospital, the main government hospital, they did about 1 cleft a month. And we have seen that pattern replicated recently in Bangladesh, where there is reluctance by surgeons involved in earning money doing these cases to be involved in a situation where they're not being paid. in Sahag in Egypt, where they are no longer receiving primary cleft cases, although it's one of the best centers in, if not the best, multidisciplinary center in Egypt, because another team sponsored by another NGO flies in and operates on their patients. And finally, support should be sustainable. And that involves the long-term vision of the local people, and especially the leader of that team. And the problems are loss of motivation. It's hard work working in a hospital which is not well supported, with equipment which is inadequate, particularly when, and this is again Sahag some time ago, surgeons earn less than $600 a month now. And then there's the lure of private practice in many countries. So there's the attraction of, why should I spend my efforts in a government hospital when I can provide more for my family by doing private practice? And there's a brain drain. And totally understandably, there are surgeons working for $100 or $200 a month attracted to work, for example, in the Middle East. So we have lots of challenges, and I haven't really given answers, but maybe some of those questions we can discuss later.
Brian, thank you. You've kept beautifully to time, thrown down a gauntlet for, in some respects, for how we work, and we might help, and where things can go wrong, which is, I think that's very important to put that right at the outset. So thank you. We're going to move straight on. We're not going to have questions now. We're going to move on through our presentations, and the next on our list is Siobhan McMahon from Alderhay, and Siobhan's not got any slides, but is going to talk to us. And Siobhan, thank you very much about your long-term experience of involvement with Nepal principally, and just to let you know, we think it's unlikely that our Nepalese group can join us because of Zoom problems, which were unanticipated. So over to you.
Okay, so thank you very much, everybody. Thank you for inviting me to join you this evening. So I have had the pleasure of working with the team in Nepal at Kirtipur Hospital in Kathmandu since about 2000. And one of the questions I was asked is about making long-term relationships with speech and language therapy teams. And I think the answer to this is possibly find a great team, because that team in Kirtipur are a lovely team to work with. And it's a real shame if Shankar isn't able to join us this evening. And I think they're doing a really good job in Kathmandu, despite the very many challenges of working in a low and middle income country. Qualified speech and language therapists are really in short supply. And when I first went to Nepal, there was no in-country training at all, but there is now an established speech and language therapy course in Kathmandu University. And it's been a really good opportunity to offer some support and teaching on that course and some of my visits to Nepal. There'll always be a turnover of speech and language therapists. The short supply means that people can be poached from one team and one service to another, and many people choose to move on either overseas or to pursue more academic interests. So I think one of the successes we've had has been being flexible with training other members of the multidisciplinary team, particularly nurses, to be what they call speech assistants. And the concept of speech and language therapy assistants is very well established in the UK. And while it might look a little different in Nepal, many of the assistants have stayed with the team long term. And actually one of the assistants from the very first group of people that we trained went on to qualify as a speech and language therapist in India, and is now the speech and language therapist working with that team. So that has proved to be really successful. I think in working in an overseas country, for me, it's been really important to pick the brains of the local speech and language therapists and other people around the specific challenges particularly with things like the speech sound system of a foreign language. So sharing that expertise with the local team, knowing the sound system very well, understanding the typical error patterns that they see, unpicking the ones that they find most difficult to manage, and hopefully as we can share our expertise in trying to develop some strategies for helping children with these, what we know to be really complex and difficult to manage problems, speech problems. I think it's also really important as a visitor to learn something about the cultural norms, particularly around things like play and behaviour and learning, which are very different from what we experience here in the UK. Nepali children are amazingly well behaved and will just do anything that you ask them to do. Little tiny children will sit and do speech practice for as long as you ask them to, and there's no moving around or getting bored. They just do as they're told, and it's really quite a change from children in the UK. And the last thing I'd like to say is that this is very much not a one-way street. I hope we've given some support and help to the team in Kathmandu, but also I've gained an awful lot from working with them in many ways, but especially around treating the many children that we see in the UK that come from a background of speaking an Asian language. Now I'm a lot more confident in dealing with them now than I would ever have been before I had my Nepal experiences. So I think everything is much easier when you have a shared experience and understanding, and those links become well established and maintained over a long period of time. Thank you very much.
Thank you very much, Siobhan. You've compressed an enormous amount into a very short period of time there, and that's most welcome. And I'm very grateful for you actually giving us the in a way the reverse benefits of this, which is so important, and I think all of us will echo that as we go on, how much we gain as well as giving. We're going to stay on the speech and language therapy theme with Marie Pinkston, who has recorded something for us on the same theme, but a little bit more related to the Bangladesh experience. So let's hear that now, and then we can pick up some of these, because there's lots of speech and language experience online as well. So over to you, Matt, for Marie.
Good evening, and thank you to both Cleft, the Craniofacial Society of Great Britain and Ireland, and to Clapper for this invitation, and to share with you the many positives and some challenges when setting up a speech and language therapy service in low middle income countries. As we know, speech and language therapy is a relatively small profession, and in some LM&ICs the profession does not in fact exist. Therefore, an important aspect when you're about to embark on a visit is to establish if there are speech and language therapists in the area you are visiting, and to see the working arrangements. For example, some government hospitals and NGOs will employ a speech and language therapist, or they may work mainly in the private sector, and therefore it's important to establish how you can access and what their mode of working arrangements are. Language difficulties are of course fundamental issues, and so important to prepare before you visit as to the language, the structure and the speech characteristics of the country's primary language. For instance, in Bangla has both aspirated and unaspirated consonants, which requires the development of an assessment tool which is both appropriate for the cultural features and also phonetically for the language itself. It's also important to share knowledge and skills with a wider group of speech and language therapists, and so that the skills are not held by one individual, and therefore supporting sustainability. Therefore, linking in with a teaching hospital and academic institutions ensures that the knowledge is shared within the future SLTs can be encouraged within the specialty of Cleft. With the Bangla project, we have links to the Dhaka University Speech and Language Therapy Department, and master's students attend the Centre for Training, and we have recently set up an agreement between the Cleft Centre, University Department and the Cleft itself the charity, which ensures and supports sustainability and the long-term future of the service. We have also set up an internship, which is pretty embryonic, but we look forward to that developing over the course of the next 6 months or so. Working with colleagues in low middle income countries enables us to think differently as to how we work and to shape service delivery. Geographical distance, transport, population size, access to follow-up and community SLTs are all challenges which require creative thinking and, of course, flexibility. Throughout my time working with the Bangladesh project and with visits to Uganda and to Ghana, it is the local speech and language therapists who have ideas and clear plans for their services. So it is about joint learning, sharing knowledge, mindful of the language and the wider context in which my SLT colleagues need to work. In Ghana, for example, there is a large speech and language therapy department, but the majority of the work is head and neck trauma, so Cleft takes a small part of their training and their caseload. But of course, in all of this, sustainability is key. We have set up supervision processes which are similar to the UK model, which enables us to problem solve together, and that we are supporting the long-term development of the local speech and language therapy team. So I'm sorry not to be able to join you in person this evening, but very happy to answer any questions via email or on my mobile. And my thanks again to everyone involved in this webinar series and to enable us to learn and share knowledge from each other. Thank you for your time.
Thank you, Matt, for running that, and Marie by remote. And again, a wealth of sort of background compressed into a short presentation there. And I'm sure there are questions and stimuli for everybody that have been raised by that. Do be thinking of what, if you're inexperienced, what questions you might want to ask, and certainly my experience has always been that the most beneficial visits I've ever made have been always in a multidisciplinary context. So with that, we're going to move on to the nursing side of things. And Helen Robson has very kindly agreed to speak to us. Again, I think she's live. I can't see screen sharing. Thank you, Helen. And over to you from Great Ormond Street. Can we hear you? I can't see you. Usual problems with the virtual world.
Can you hear me now?
I can hear you now. That's great. Thanks very much. Over
and
to
you
you.
can see the screen?
We can indeed. So
Right.
there you go.
Okay. Well, just to echo what everybody else has said, thank you very much for inviting me, and thank you for the three organisations for setting up this evening's webinar. So I'm Helen Robson. I'm the lead nurse for the North Thames Cleft team. And I've just recently returned with Brian and the team from Bangladesh with Cleft Bridging the Gap. So I'm just going to discuss the role of the nurse specialist. So, okay. So looking at global development within nursing, so nursing is in quite a unique position, as the nurse generally knows how the patient lives their lives. Nurses can have an influence on health and influence policy, and they're in quite a unique position within the health system and the community, and also have that unique awareness of cultural, religious and social determinants. So in the UK, as we well know, the nurse's role became specialist and integral part of the Cleft multidisciplinary teams around about 2000. And we provide holistic care from antenatal diagnosis to adulthood, and act as interface between the multidisciplinary team, the patient and the family. And our role is essentially around, apart from antenatal diagnosis, but postnatal diagnosis, where the baby is born, and obviously cleft palate detection particularly, and with feeding and airway management. And then we go on to provide support perioperatively, ongoing referrals, so liaising with people like speech therapy, audiology, dentists, those kind of organisations, and obviously providing health promotion. So developing the role. So Visiting other countries, I think the most important thing for me as a nurse is to work within existing practices and recognising the role of the nurse. So certainly in Bangladesh, and also speaking to Chris Kuhig is also on this call, the level of education of the nurses, and most of the nurses seem to be educated to master level and have attended extra education and taken that time really. Supporting them with their myths and folklore, which is certainly something quite pivotal in some of these countries. And they're not there to change things. Some things actually work really well. So things like pain relief, I found particularly well managed compared to where I work in the UK. Looking obviously to support pain feeding and looking at their records, because obviously that's very, very different. They're back to the old books and things like that, and lines down books and graph paper and that kind of thing. And looking at things strategically. So, as I said, exploring how the nurses work locally and accepting and understanding variances. So some examples that's already been mentioned tonight, that certainly in Nepal, that the speech and language is the nurses act as an assistant for speech and language, and also the nurse provides first aid as well, and that's part of their role. In Dhaka, the nurses work in theatre, they scrub and they recover. And we've recently trained a nurse to provide the audiology testing. I'm working with the audiology consultant. So I'm looking at the future, where we're going with this, and obviously sustainability is key. We've looked at perhaps inviting the nurses to attend UK Cleft courses or visit to UK Cleft centres, and looking at virtual keep in touch events. So obviously when we are over there, we're invested very much, but then we don't speak to them for a while. So it's really important to forge those links, which we hope we're doing really. In developing other roles, like I've already said. So for instance, the audiology, or maybe providing dental health, which is something certainly that was noted when we went to Dhaka this time. And also maybe developing the role of an outreach nurse, so they not just at the centres, they may be able to work across the rest of the country. And thank you.
That's absolutely wonderful. Thank you, Helen, for enlightening us with your experience. And I know there are other nurse specialists on the line, and certainly it will be really exciting, I think, to explore this a little bit further later on, the entire role of nursing and the holistic role that you have forged with the team whilst surgeons are getting on with doing some operating and so forth. We are going to move now to another pre-record. I know David Sainsbury is actually online, but he's kindly sent us some slides which he will be able to address later on. So, Matt, if you can run David's slides, thank you, about setting up a new.
Thank you very much for the opportunity to talk at this CFSGBI Pre-Conference Webinar Series on Global Cleft Care. My name is David Sainsbury. I'm a cleft surgeon in Newcastle upon Tyne in the United Kingdom. I've been asked to talk about setting up new twinning arrangements and the lessons that we've learned with our collaborators in Nepal. I think the first thing to do is to find your twin. This may be because you've visited a country before, worked there, for example, on your elective. I was lucky enough to go to Kathmandu in my medical elective as a medical student, and I was keen to build that relationship with the people of Nepal because I love the country. I love the people of Nepal. So we were very fortunate to find the reconstructed team at the Kirtipur Hospital and their Cleft and Burn Centre. And then the underlying principle, I think, behind any collaboration is that we go as an invited guest on the host terms. And then that sets the tone for everything that happens thereafter. And then the next thing to do is to go on an exploratory visit. This could either be you as an individual, perhaps later on go with members of the Cleft MDT, because they will have expertise in their particular subspecialty areas. So, for example, here's Siobhan with the speech and language therapists and nurses. Here's Chris in Kathmandu, who's one of our specialist nurses in Newcastle upon Tyne. Those members of the visiting Cleft MDT can then work alongside the host team. And then fundamental to all of that is building relationships. I think you need to build trust, because you're going to have to be vulnerable. The people you're working with are going to have to be vulnerable and trust you when you're discussing things that they're struggling with or things that they need help with. So that's fundamental to everything that happens from then on. And then once you have that, you can find areas to collaborate on together, to work together for yourselves and for the host team. You can identify short and long-term goals. So these could be relatively simple things in the short term, such as equipment, surgical equipment, nursing equipment, toys, dental equipment, to more long-term equipment goals, such as buying a microscope, which is obviously an expensive piece of equipment. You can collaborate together on teaching, either in the host country or inviting people over to your own centre and other centres to learn. And teaching can be done, from a surgical point of view, a nursing point of view, dental point of view, across the MDT. And then another area that we found is very useful is research and audit, and monthly Teams meetings of facility. So in summary, I think the key things are to find your twin. Underpinning the whole visit and the ethos is to go as a guest on the host terms. An exploratory visit with the Cleft MDT is very helpful. Building relationships, building trust, finding areas of mutual collaboration, and then setting short and long-term goals. Thank you very much. I hope that's been useful. It's been a real privilege and honour to work with the excellent team at the Kirtable Hospital in Nepal.
Thank you, David, for that. That was absolutely excellent, and I imagine you've had to. We cut you down to time. There's so much you could open out, and we hope you'll be able to do that later on. So thank you for running through that with us. I'm hoping now we will go on to another record from the other side. We had hoped Shankar Rai would join us live, so he could talk about things from the Nepalese perspective. But we do have Papon, who has for a long time collaborated with Brian in Dhaka, and I think there's a pre-record for him. So Matt, if you're going to run again now, if you can fire away with the next video, thank you.
Hello everyone. This is Dr. Mohammad Rovin Karim Khan Papon, Associate Professor and Lead Surgeon, Comprehensive Cleft Care Center, Sheikh Hasina National Institute of Burn and Plastic Surgery, Dhaka, Bangladesh. I am going to give you an idea about role of NGOs for cleft care in Bangladesh. Every parent desires to have a healthy, beautiful baby. But sometimes baby born with burn defect like cleft lip and palate, which is emotionally challenging. Cleft care is very expensive, which is not an option for the poor people. As cleft lip palate is not a life-threatening conditions like dengue, AIDS, tuberculosis, our government is not giving priority for the cleft care. Even parents don't know that this is a treatable condition. In Bangladesh is a low and middle income countries where 30 to 40% people lives below the poverty level. Around 5 to 7,000 cleft lip baby born every year. On the other hand, around 300,000 unrepaired cleft patients are there. If anyone is fortunate, they get the chance to have an operation. But sometimes it is done by inexperienced or occasional cleft surgeon. Very rarely, these operations are done in the government hospital, mostly done in the private hospital or by the NGOs or by the overseas missions. They come in, do the operation and fly out, leaving nothing behind in terms of training or further follow-up. About 10 to 17 NGOs are working in Bangladesh for the cleft care. They mostly do the simplest cases, few secondary cases, no complex craniofacial cases. The main role is played by the surgeons. There is lack of coordinated multidisciplinary care. You know, cleft lip and palate, there are some dental problem, some speech problem, some hearing problem, and also some feeding problem. It is good to know that Cleft Charity UK works in the government hospital. They have trained surgeon, anesthetist, speech therapist, orthodontist, coordinator, and nurse. So here in Bangladesh, at the government hospital, Sheikh Hasina National Institute of Burn and Plastic Surgery, we have ensured speech therapist to assess speech and ensure therapy, orthodontist to ensure dental care and dental hygiene and orthodontic care, and expert pediatric anesthetist to ensure safety of the anesthesia during and after the operation, and cleft nurse for the nursing care and for the feeding advice. And this Cleft UK provide us complete sets of equipment for the cleft surgery and also good anesthesia machine to ensure safety of the anesthesia and very good quality camera for the video recording and for the BPI cleaning and for the photographic documentation. My question, if all the NGOs leave Bangladesh from tomorrow, what will be the fate of cleft care in Bangladesh? And I request my government to ensure good quality infrastructure for the cleft care and to ensure proper training for the cleft surgeon, speech therapist, audiometrician, orthodontist, and others. I am grateful to my mentor, Dr. Brian C. Somerled, who is working relentlessly to ensure comprehensive multidisciplinary care here in Sheikh Hasina National Institute of Burn and Plastic Surgery for last 28 years. Thanks a lot for your patience here.
Wow, I hadn't actually seen that before, and I think that's an extraordinarily powerful piece, and I think very, very salutary for us all, and it certainly rings true, and congratulations on all those who've been working along with Papon and his team over so long to do what they've done. We'll have discussion on all these things in due course. We have, I think, if I'm correct, Matt, Shankar Rai, I've been trying to look at email, hasn't been able to call in, and Trina Sweeney can't from Ireland either for some reason because of Zoom problems. So our last speaker, I believe Chloe Roland, is with us. I can't see all the attendees on my screen, but I think Chloe is going to fill us in on the. Chloe is an orthodontist from the Northeast Thames team, and she's going to tell us about some of the dental aspects that she's come across with work with them. So Chloe, over to you.
Thank you very much. So this is a bit of a kind of general question posing about how we can facilitate cleft care, both for dentistry and orthodontics. So how we can make a difference to other teams. Okay, perfect. So in terms of my involvement, I currently work for Cleft Net East, based out of Addenbrooke's, which serves the whole region of the east of England. And I've had some involvement in the International Steering Committee for Cleft UK. I've also participated in an online webinar for the Circle of Cleft Professionals, which has an interest in teaching and bringing together people who are interested in cleft MDT care in low resource settings. And I've now participated in a few trips to Dhaka in Bangladesh to support the team over there. So we all know that ideally we'd love to have all of these people present in the room with the patients to help in decision making. But this UK model is not necessarily always practical. But it's really important that we kind of still instill this idea of an MDT working. So there are quite a few challenges when it comes to cleft dental care in particular. So one of them is to do with cost. So even in the UK, dentistry is incredibly costly. I think the NHS remained free in terms of dental care treatment only for 3 years. It then rapidly moved on to charging patients. So you can imagine then in an LMIC context, it can be quite difficult to fund this care for all. There's the fact that we can have quite a few treatment phases for cleft children and lots of different protocols. So starting from infancy or birth and then kind of well into adulthood. Particularly in an LMIC context, but also in the UK, there's a high rate of primary disease, caries, gingivitis, which can compromise any surgical outcomes and any outcomes for those patients. And we know that cleft children are more prone to these things. Prevention doesn't seem to be very high up on the list in dental care. And we know that prevention obviously avoids a loss of issues in the future. And that's one thing that is lacking in cleft dental care. And also we know that it might be difficult for some to access those centres where they might be able to get care. So in an ideal world, I'm sure an orthodontist would walk in and say, these are all the things that we need to do absolutely for every single patient. And particularly when you look at an American model, you have an intervention all throughout a child's kind of first 20 years of life. So I think we have to think about how to adapt some of these ideas that we have to a lower resource setting. So things like very early input from paediatric dentistry or an orthodontist to be able to counsel both team members and families in terms of their role and what to expect for the future. Focusing on primary disease management and prevention, so things like fluoride, which is not always available or understood in every context. Trying to help the local orthodontic team to prioritise interventions to reduce the burden of care overall. Lots of studies have been published kind of all over the world, and it seems that on average it's about 10 years of orthodontic treatment that cleft children undergo, which is not always realistic. It's also important to prioritise local care and follow-up. It's not realistic to have external intervention for orthodontic treatment, since patients tend to be seen every couple of months. And with a team, it's important to devise a local evidence-based protocol that will be adhered to, that is reasonable when it comes to that population. And so these are my thoughts in terms of how we can make a difference as UK teams. So things like modelling the multidisciplinary treatment planning, so making sure that, you know, there is visible discussion between the maxillofacial surgeon and orthodontist when planning bone grafting, promoting preventative strategies, although they're not quite as exciting as, let's say, very complex braces. Really, the kind of prevention message is number one. Providing resources such as instruments or journals, which might not be available in every setting, or let's say just to be able to help them in terms of ideas. Teaching, so getting involved in a local training program, university. Mentoring, so things like meeting with some of the orthodontists to discuss some of their protocols, case discussions for problem solving, which can be done remotely, and supporting any research and audit ideas they might have. And really lastly, thinking about supporting sustainable care models so that you are not making your peers dependent on your input forever. Thank you very much.
Thank you. Thank you very much. That's again a whistle-stop tour through one of the things that I've always found extraordinarily difficult to get integrated into the work that I've been involved with, which is the whole dental care. It seems much more difficult. we've now come to the end at I think almost perfect timing of our prepared talks. So what we would like to try and do now is get your feedback and really see if do feel free to put your screen on if you would find that helpful in sort of interacting. And this is your opportunity. You've got to imagine this as a big room, and there's lots of experience, but there may be lots of people who have questions about either the way Cleft has some of the challenges that have been presented this evening, or just getting started. Would anybody like to sort of kick off with any particular questions? If you can feed them through in the chat column as a simple start. I would like to begin with perhaps to ask our speech and language therapists how well they think, maybe dental and nursing as well, but the non-surgical disciplines, how well we're managing to make inroads into this world where the need burgeons all the time. We know how quickly population growth is going around the world. Are we keeping pace with training, adequate numbers, or not? Is that an obvious answer to that? Anybody like to get the ball rolling? Or Brian, thank you. Hand up.
Well, really, just to say that there are still countries with virtually no speech and language therapy activity at all. One of the countries we're involved with is Iraq, Kurdish Iraq. There is no speech and language training program, and there is one speech and language therapist who was trained in Iran and works in Sulaymaniyah in the Kurdish region where we're involved. So it's interesting that it's a better off country, but has obviously never seen the need for speech and language therapy. And of course, they've had 50 years of war, so it's I guess it's understandable.
I mean, Brian, that may lead us into those. I don't know how many involved here are involved in Cleft work in LMICs already. But if people aren't, how do we find the gaps where there is a need? There's clearly a huge need for training and around the world. How do we begin to get a handle on that, where to make these links? David has described very well, I think, the starting steps for getting a twinned unit. And it will be one of our visions is to see every unit in the UK twinned on a long-term basis with at least one other Cleft unit globally. How do we begin to find those places? Does anybody have any suggestions, or has it always been serendipitous where somebody's done an elective or happens to know the language or has a contact? Any thoughts about that? How we get started? I wonder whether Matt, you've become aware of some need, a request from Tanzania, haven't you? Where you're aware that there may be quite a considerable need. Do you want to just tell us a little bit about the background of that?
Yeah, well, I haven't actually connected with this surgeon from Tanzania yet. I know that Debbie was in Ethiopia with Francis recently, but it came to our attention through another charity and seemed quite an exciting potential because he was setting up a new team and had a team ethos. But I'd be really interested to know from David maybe about the finding your twin, because if one person of the team finds a good link with someone else, is that enough, or do you really need to find out what your team's fit is, and how do you find that whole match? Because that's what we're trying to do, isn't it? Find a whole team match. It's not just about an individual match to someone else.
Well, I think I found the Coachable team, that was by luck via Bruce. And then I went on a visit myself and thought, yes, we could, there is potential here. And then we had another visit with members of the MDT, and then that allows those members of the MDT to feed back and see whether they think it's a fit. I mean, I think in terms of finding a twin, I was perhaps quite lucky and it was quite straightforward. But I guess Cleft is a good platform for that. Cleft the charity, hopefully as it becomes more well known around the world, if teams do want support, then they could approach Cleft. And I know we've discussed that in the International Steering Committee, potential twinning arrangements. That I guess that might be one way of doing it.
Yeah, thank you, David. That we've had a comment from David Drake in the chat. David, thank you very much for joining us. And you've said links through personal, medical, and Cleft connections. Once you visited, allows other team members to get involved and identify needs. I mean, one of the, I guess, underlying all this, some of the rationale behind having this webinar is to present perhaps a different philosophy from that espoused, as we know, by some of the bigger Cleft charities. It's reasonably easy to sign up with one or other of the big ones and go and visit somewhere and do some Clefts and some Cleft surgery, but much more difficult to build these relationships. David, do you want to come in on that? Thanks very much. We can see you on screen now. Yeah, but are you muted? No, you're not. Thank you.
Oh, thanks, Tim. I think, historically, I started off as one of those sort of visiting places and doing some Clefts, I guess, looking back 25 years ago. But in the last 15 years, we had a very strong relationship for a long time with Nagpur, in the unit there, and developed memorandums of understanding and taking lots of different team members, speech therapy, nursing, orthodontics and dentists to develop across and working with their university departments. And I think if you can get involved with the universities in the city or town that you're based in, then that allows you to develop sort of multiple levels in terms of what you can develop there. And then you can develop professional links and sort of peer-to-peer support, whether that's by locally or bring people visiting the UK, which we've done. And also now, of course, with the technology, it's much easier to help and support people. And because of some of the issues with being based in India as an NGO now, we've not we still have links with Nagpur. We don't visit there because we're not needed, to be honest with you, in terms of developing as a surgical, in terms of supporting the surgery there. But we then start to develop a link with the University of Hanoi, and again, it's through personal contact. But they're interested in developing a Cleft service, so it's not really about delivering surgery. It's about particularly helping them develop speech therapy. There's no speech therapists in Hanoi, which really surprised me. So it's about demonstrating a need sort of on a dental, speech therapy, nursing and support like that. So that's certainly been my personal experience. I think it's finding somewhere that's looking for the package of Cleft care rather than just going to deliver surgery, which is the old historical model that some of us will have worked under.
Yeah, indeed. Thank you, David. Really helpful. And Debbie's come in on that about beginning these relationships, which I think so much of this, it goes back, many of the speakers have put this very clearly, that it's developing a relationship with people. Debbie, do you want to, particularly important in maybe in speech and language, where we really have to understand the differences linguistically between communities. Do you want to comment at all, Debbie?
Yes, well, I think to start with just that question of how do you find your team, your twin at least, and that is about a relationship between probably the surgeon, as they tend to be the sort of person to lead on these relationships starting, and it feeling right, and having common philosophies. So I think that's absolutely fundamental, and that has to grow from somewhere. And I realize that doesn't answer quite how you do grow, but it's probably about going to meetings and meeting people from all over the world, which is really opportunities we do have now. As far as speech therapy goes, what was your question exactly, Tim? Because I was thinking about that rather than speech therapy. But in terms of, in exactly the same way, you build a relationship with the therapist, as Siobhan has pointed out, and as Marie has pointed out, if there are therapists there. Now, it was very interesting hearing Siobhan's talk and then Marie's talk, and it's a shame Marie isn't here in a way to answer, because actually what Marie was talking about was something quite sophisticated now, because they have the course in Bangladesh. She's very much involved in training the students there, and that's brilliant. And I would say that over the decades I've been around, the courses have developed we started in Sri Lanka, and Bangladesh took the model, actually, took people from Sri Lanka to go and do that course, to start it at least before it got into the university. And Uganda and Ghana and Ethiopia. I mean, there are lots of examples of the courses starting to grow. So it is interesting, Brian, why Iraq doesn't seem to have that course. But I think that going back to Siobhan's talk, which I was really interested in, I've been the Speech Task Force in the Cleft Congress 2022, Felicitas Congress, was all about non-speech therapists providing speech services. And we've just actually about to submit a summary of this piece of work, which has been done by different people from all over the world, to try and see if we can understand more about what different people can do, be it the nurse and what sort of training they need, be it an assistant who has more training, and then what happens to their jobs. How do they get their supervision? How do they get their mentoring? And mentoring is a big thing now in speech therapy that we're able to do with technology. I'm speaking for much too long. As you can see, I could go on for a long time. But so there are lots and lots of questions about speech therapy, and I don't think they're simple at all.
No, thank you, Debbie. I think one could argue that actually a lot of the funding from the big Cleft charities ought to be going to to where we haven't got, and where the disciplines just don't exist, and
Yes.
and stopping or changing, skewing that very, very dramatically. And one of the things I wanted to say, just and long-term relationships, I can see sort of hiding behind her name is Jane Sibley, who has built a very long-term relationship with the Ugandan Cleft group that we've worked with, and probably failed significantly to do very much on the surgical front in the long run. But I think your relationship, Jane, with nursing development has been one of it's been gone on for at least maybe 10, maybe 15 years. I can't remember how long you've been involved, but I'm sorry to sort of put you on the spot. But it shows that you've empowered the nurses there, and it's been probably the most effective thing that's happened in that unit.
Yeah, I mean, I can't remember exactly how many years ago, but it's so true that you do go in there as an invited person and then stick to feeling like an invited person and just go in there and see what they're doing, because it's really important not to introduce anything that's not going to be sustainable for them. But I worked with Bertha, who was or is one of the nutritionists, and she was really keen, and we got a really good relationship going, and I probably visited there 3 or 4 times, and Bertha came back and spent some time in our unit in Oxford. And now she's really motivated, and she speaks, and I think, Tim, you met her at a conference somewhere. She was speaking. She's just so motivated, and she's come such a long way. She's actually temporarily left clinical work at the moment to further her studies, as someone else was saying. I think it was Helen often saying that, they're really highly trained up to master's level. So I think she's just gone off to do something. But I'm hoping that she'll come back to it, and we do stay in touch. So, but yeah, it just shows that some of them are so motivated and really want to learn.
Yeah, thank you, Jane. I mean, that's your work there. You've got a local evangelist from Uganda, effectively, for cleft nurse, the value of cleft nursing care, and she's spreading their word within her own. It was actually a COSEXA, the College of Surgeons of East Central and Southern Africa, that she was speaking at, and getting the message out there. And it comes much more powerfully from somebody who's been through that background. And so that's a one-on-one, and you have no idea how influential that relationship has been in the long run. So that's really, I think, where we as Cleft would hope to support. Well, there is a question in the chat about how do the long-term relationships develop and change over a long period, and do needs and priorities change? And I think you might say that with your nursing care there, you've probably outgrown the need to support that particular unit, and you could, in a sense, move on somewhere else and do more, but can continue to support that person. Does anybody have any answers to that question in the chat? Any sort of hands go up? I can't see any.
I don't have any definite answers, Tim. I'm Sophie. Hi from Newcastle, but
Hi,
I've
Sophie.
had a bit of experience of seeing the relationship develop with the twinning that David has set up. And I've never been to Nepal, but hopefully one day will. But it's been really nice to see the relationship build over kind of the past year and a bit since Dave started it. And we've had involvement in the sessions that Dave is trying to keep going monthly. So whether that's just kind of teaching bits or kind of discussing research projects, how they can develop theirs, or giving them tips and advice on their projects, and then maybe showing some of our project work that we've been doing. And obviously seeing the surgeons that have come over, like Kamal and Pramila, and building relationships with them, having never been over, is really nice. But I think the main thing probably for our unit is having someone like David actually leading it and keeping those things going, because I imagine it's very easy to suddenly stop those monthly sessions. You know, you do sort of find yourselves running out of things to say sometimes, or, you know, thinking of things to present next. But just having someone kind of there that's continuing to run those monthly sessions, whether all of us attend or not, I think is probably really valuable.
Yeah, I think that's when you're in this for the long run, you do need some stamina, some sort of long-term stamina to keep things going and to see it develop. So it's really important. Everybody seems to have sort of bought, in a way. I guess maybe we're preaching to the converted a little bit, but there's buy-in on the model that Brian presented right at the beginning, and David's outlined, and all of you have all the speakers spoke to, which was really about the sustainability, the long-term relationships, the relationship being one of definitely a partnership and an invited partnership. Does anybody see any as a Cleft charity? We obviously want to promote relationships which we think are on the right lines. Does anybody see any holes in this or any problems? Anyone tempted to just go and join up with some of the other bigger charities that are, or is it? I want to be provocative, really, but are we all singing from the same hymn sheet? Kurum, you've hand up? Was that a hand up?
Yeah, there was a hand up. Correct.
Very,
Hi, Tim.
very gentle one. Hi, Kurum.
Gentle hand up. Yeah. I guess the issue that we just had a couple of weeks ago with the Philippines is that both the speech therapists on the first day informed us they were leaving within the year because they had been trained up in a certain way. And I've seen similar things happen with surgeons as well. Once they learn a certain skill set, or they've got some overseas experience, perhaps they've twinned and come over and done an observership, then it strengthens their CV, and then they move on. So that can be an issue, particularly when you're trying to develop a relationship.
Yeah. I mean, I think that's a big. There's a huge question underlying that, isn't there, about sort of the relationship with and development and income levels and so forth, and the balance of power globally. and where things exist. And I think the last thing we can ever be is proscriptive about how people behave in the face of all the challenges that we can never understand. That will be my take on that. I certainly have over many years felt, from a personal perspective, if one trains 10 people and one is left doing the sort of role that you envisage them doing, that's a result. And maybe certainly from my experience in some parts of the world, the death rate from HIV, road traffic accidents, all sorts of other things was really significant amongst people we trained. So one had to almost build that factor into, and then others leaving, as you quite rightly say, to sort of pastures greener. That one can't blame that happening. We don't have any prescription for that. But I think who we choose to work with and train, we can just be partners, invited partners with, and people like Papon and Shankar Rai are really wonderful in that aspect. I see Henry DeBerker's put in a comment in the chat. Do people have any experience of setting up financially sustainable services, support accessing local funding? Do all LMIC centres involved require charitable funding from high-income organisations? Very good question, Henry. Sorry, that's a very good point. This brings in the whole subject of sort of dependency, the whole aid culture, if I can put it that way, versus sustainability. Anybody like to comment on that? I certainly, looking at the Bangladeshi model, that seems a whole lot more sustainable in the long run. I don't know whether, Brian, I can bring you in on that, because you know in detail over many years what's happened with funding in Bangladesh, and how sustainable is it? How dependent is it on external aid?
Thanks, Tim. In terms of working in a government hospital, ideally, it should all be funded by the government. We haven't yet achieved that. We're moving in that direction, but it's up and down. And I think one of the important things about keeping this commitment is to make regular visits. Keep involved. I thought a year ago that we were onto something big because we had links with the cabinet secretary. There was then an election, and he's gone. But amazingly, a plastic surgeon whom I met in 1988, who visited Billericay, and I've sort of kept in touch with ever since, but rather remotely, received a call about 3 weeks ago from the Prime Minister to say, you are now the Health Minister. So, you can be lucky. And I hope that might be a very fruitful area to develop. But, governments change, individuals within governments change. So it's a struggle. And one thing that we are trying to do in Bangladesh is to set up a national foundation, ideally to involve all the NGOs. But as Papon said, if NGOs disappeared in Bangladesh tomorrow, the whole system would collapse. Probably at least 95% of the clefts in Bangladesh are operated on through NGOs. That's got to change. But that has to come from the government. They have to recognise that need.
Yeah, and that's we're in this for the long haul, and there are no easy solutions, are there? And what springs to my mind actually is a College of Surgeons initiative that, the country I can't talk about, but and it's not related to Cleft, but they were a long way down the line with a very big partnership initiative, and the health minister then became ill and has changed, and the pandemic arose and things fall apart. And however, this happens to the bigger organizations, it happens to government links and so forth. So there's a lot to be said. David, I think is that David Orr's now put his hand up? Yes, it is. Yeah. David, thanks very much. I'm glad you could make it in, despite the fact that you might have got shut out from.
No, well, I'm actually in Scotland as we speak, so I was able to Yes, yeah. No, just I think that just to the point about government funding and sustainability and that sort of thing. I've been involved in a project, since about 2006 in Ethiopia. And really the project has been broader than Cleft. It's been really trying to set up a plastic surgery unit and sticking with it over a period of years. Although we have been supported in it by another Cleft charity, by Operation Smile. All of the local structures have all been built by the government, and Per and I have always said all the way through, look, if the government and if the health service isn't interested in this, we're not interested in it. We're only interested in it if this is something that you want to do. And they have they've kept ownership of it all along. And we have got to that point where, having probably arranged and helped training for about 6 surgeons, we've finally got 3 in place, and that's enough for them to set up their own training program. And eventually, having started out as a hospital that had just 1 surgeon and no safe anesthesia, we had to start off by building medical anesthesia to layer things on, and then develop other surgical specialties, and then develop plastic surgery within general surgery, and then eventually but this was all something that they wanted to do themselves. They had long-term goals to do it, and we were in the fortunate position of simply being able to respond to their requests at every step. And I think and the good thing about that is that there's an end point, and the end point now is actually, once you have a unit that has training accreditation, actually you don't need outside people. You can do it yourself. So from that point of view, which is another thing I think I just wanted to introduce, is the idea of, when does your project end? Because I think it's very important that these projects have a goal and an end. So that you can say, look, we've finished this phase of it and we're now disengaging, but we'll remain friends and collaborators. And if you need us to do something at a different level, we can do that. But it is important to have an end, I think.
Yeah, that's excellent. Thank you, David. And you've, we have to salute all you've done there, because you really have generated something in the long term of enormous value. Interesting sort of rider would be, how dependent are they still on, even though it's sustainable and locally sustainable, is it still dependent on some external NGO funding?
No, I don't think so now, actually. And also, I think, and I think that the amount of funding that they got, because it's a university hospital, I think that's Brian's point again. You're dealing with a government hospital, a training center, a university hospital. It's the healthcare structure that the country has chosen to adopt. And if you can work within that, what the NGO provides has been a tiny fraction. And if that NGO disappeared out of there tomorrow, I think it would make very little difference. I think that the project is done now.
Super. That's a great concept to introduce. Thank you and before I go to Matt, I'm just going to mention David Drake's comment in the David, you've said that Smile Train actually, for all the problems that we know that they can generate, but they've given support for rural families, for travel and so forth. So they have really supported the university team in developing a what sounds like a more multidisciplinary Cleft network. So that's a very significant positive. Matt, you had a hand up, so I didn't want to miss that. Or were you just drawing my attention to that?
No, I was just going to follow on from Henry's point about setting up financially sustainable services, and David's comments from Ethiopia, because a very dear friend to me, Jackie Riley, has joined us from Project Hurrah, and I'm so sorry to put you on the spot, Jackie, but I'd love to hear just your experience, because Jackie's not a medic. She's the head of Project Hurrah, and I think a number of years ago, they set up a local office there, and the local office in Project Hurrah was doing a lot of their own fundraising. So it'd be really interesting to hear your experience of that, Jackie.
Yeah, so I was looking for the hand button, so thank you for saying that. So Project Hurrah started work in Ethiopia in 2001. And actually, Matt did an early review project in 2011, I think. I was just looking in the files, and 2013. In 2015, we set up a separately licensed Ethiopian charity. To all intents and purposes, it has until recently, we've been a funding arm in the UK. And Project Hurrah works in partnership at the moment only with Smile Train, but we're open to working with other partnerships. For the first time last year, we were able to secure funding directly from Ethiopia. And this was really a fantastic situation from a sort of, I would say the sort of emerging entrepreneurial, business community. And so, but that was literally, so that was the first time we've had funding from Ethiopian people in Ethiopia. So this is a new kind of chapter for us, where we have a renewed board in Ethiopia. We have two boards which work closely together, but effectively, for all intents and purposes, as one charity. I think, and as David, you're speaking about, the GIMA, the operations GIMA, which is, I've had some conversations with Abby. I'm not sure, I can't remember his surname. It does seem a completely different model to other sort of situations in Ethiopia.
Yeah, I mean, it's the government unit. It's the government hospital. It's the university. And I think our role has just been facilitating and helping and pointing people in the right direction, and maybe coming over and showing people how to do stuff, But I mean, my experience of going back there has been that you go there 1 year and you show somebody how to do an operation, and you come back a year later and you bump into somebody who's showing you, who's saying, "Look, hey, look what I've done." I said, "Oh, who showed you how to do that?" They said, "Well, he did." I said, "Who showed him?" "Well, he did." "And who showed him?" "Oh, you did." So it's very and I think particularly when you're working with very well-trained surgeons, really good people, they can pick up stuff really quickly. But that's the advantage of being in a government training hospital where people are committed to the overall project.
And I think the difference, I think, in the model of my understanding and the model of the GIMA university is that those surgeons, once they're trained within that facility or within that project, they work as volunteer surgeons, I'm told, as opposed to being paid a certain fee, which is the situation with other organizations. Just while I'm sort of here, the other thing which is quite exciting, and I don't know if anybody else sort of knows about this who's working in Ethiopia, but the Federal Ministry of Health has just set up a department for the first time for congenital birth abnormalities. So it's never been really recognized, or Cleft, or has not been recognized as being a focus for the government. So that's interesting. Project Hurrah is sitting on the advisory committee along with Operation Smile Train, and the College of Surgeons in Ethiopia. So it's a kind of a new chapter.
Thank you very much, Jackie. That you introduced some really interesting aspects to that. I'm aware we're entering our last sort of 10 minutes, or at the most, really. And we haven't talked very much about dental work. We also haven't talked about, we've had no interface. There is a separate webinar, as you know, on research. But actually, there is an enormous desire, in my experience, in the low middle income countries, for people to answer questions, but to do, and our involvement. I don't know whether anybody has any comment about that and how not to be. I can think of a zillion examples of patronizing, abusive research, taking things the wrong way, but I can't think of huge numbers where it's generated and supported properly from the partnership basis. But does anybody have any comments on either a little bit more on the dental side? To my mind, it's been one of the hardest things to establish is really good relationships with dentists and skilled orthodontists, let alone the more complex stuff for the rare craniofacial clefts. Anybody have any thoughts about dental care or research relationships at all? Or anything else? Brian, thank you. You're muted, Brian.
Two questions. Dental care, I don't know if Chloe's still there, but yes, she is. The problem of caries in so many countries, particularly in Asian countries, where sugar is, where everybody just loves sugar, it really it handicaps everything that we're trying to do. So I think preventative dentistry is a really, really high priority. But I was just going to ask a question or make a comment about twinning, because you talked about twinning early on, Tim. I think this is something that we ought to really be expanding in the UK. And David talked about finding the twin. Problem is that the best developed centres are the ones that know what they need. And the ones that are very undeveloped have no idea what cleft care is all about. And we can contribute in both, I think. I think David would agree that lots of what's going on in Nepal is actually high standard. And there are gaps, whereas Bangladesh there was nothing there, basically. There was it hadn't even begun. So there are different levels at which you can come in, and the centre which is most likely to ask for you is actually probably the one who least needs you. We just had a request from the Royal Jordanian RMC in Jordan yesterday about involvement, and that's already a pretty well developed service. So I think we ought to become like a marriage bureau for twinning.
Yeah, that's very helpful, Brian. Actually, we have got a lot of experience. Your long-term relationship with Bangladesh and David Orr's with Ethiopia. You really have shown what, if you're really in it for the long term, where there's nothing to start with, you've provided that sort of comprehensive, sustainable care. But I think there are other models, aren't there? There are other ways of moving. But I think what we do want to do, well, I'm going to move to some extent a bit now towards sort of summing up, really, because I think what we really do want to know is we want to, as a charity, I think we want your enthusiasm, your support, to know whether you are behind the whole concept of twinning, and if so, how we can facilitate that and have the dialogue together with ideas, places you've got where you may have a link, where there's a gap, in a sense. I don't think we want to sort of march in and push others out. There may well be a time for some advocacy and some political work to address some of the ills that I think Brian and Papon certainly fleshed out in their talks. But we do want to know what your ideas are, and to build this relationship across the UK with through the Craniofacial Society link with all cleft units, to see how we can produce sustainable models in the future. And so I think we've heard some really good ideas this evening, and lots of sort of examples. Brian, I don't know whether you have, is there anything else you want to ask about or to mention about twinning? Because twinning is a concept that I was originally, one sees signs as you come into Oxford, we're twinned with X number of places, and actually they've crossed one out recently because it happened to be in Russia, which was very interesting. It's been blanked out. So things can go backwards and forwards, but twinning actually has enormous strength and power if it's done well, and we've had exemplars of that this evening. So would anybody else like to any questions or comments before we actually come to draw to a conclusion at all? Any hands want to go up at all? Brian,
can I just make one point about twinning?
Yeah,
it's expensive. It's expensive. It needs funds, and we're very aware of that in Cleft. You know, a big team visit to a place it costs a lot of money, and I would love to see a little of the money that's going to maybe less worthy causes come to this sort of idea of building a sustainable centre. That's what it's all about, isn't it? Of not of building it, but of assisting in the building, of supporting the building of sustainable centres.
Yeah, thank you. And just one thing flashes across my mind, and that is that for quite a long time, I don't think it's changed. The NHS has been very supportive of in conceptually anyway. I don't know how practically, certainly not in financial terms, but in supporting twinning arrangements between units here and globally. They often, in the past, they did want to have the NHS logo attached to such links, so there was a little bit of sort of self-interest in that. But I think there is something. There are areas where we can play on that, and we can approach local managers and so forth for at least some degree of support, some sympathetic support with as teams begin to work together. Because as has been drawn out earlier on, there's a big benefit in the end. For people who do work, you bring an awful lot back. Certainly, Siobhan mentioned that right at the outset, and we all know that there's a lot to bring back, and we are the ultimate beneficiaries from these relationships as well. So, I think the take-home message is this is hopefully our ethos. It's interesting how much buy-in there is from everyone here, which is great. I hope it's not just. I hope you have mention anything provocative you wanted to, but I think as a starter and laying the groundwork for what the link with Craniofacial Society will be, that's what Cleft wants to do and wants to support. And thank you all for your time this evening, and actually throwing your lot in and being willing to and wanting to work and do some work, because this is not paid at all, not even attending these things, but all the work you do is supported minimally, I think, by Cleft charities and so forth. So thank you for your support for Cleft itself. Anybody, I'm going to hand back to Melanie if there's anything you'd like to say, Melanie, just to conclude and to draw us to an end. Oh, I've got your screen.
I just want to thank everybody who's contributed, all the presenters, expert steering of us all by Tim. So thank you for that, Tim. And I also want to take this opportunity to advertise our next webinar. So Wednesday the 13th, 6 p.m. The next one is being led by Clapper. It's entitled The Lived Experience. So for those attending, they'll be able to gain patient perspective on the Cleft journey and learn how Clapper services support patients, families, and the NHS. So please come along, please spread the word, pass on the link to colleagues, and we look forward to seeing you all next Wednesday.
Thanks very much, Melanie. Thank you, Matt, for organising this and running it so ably. And thank you all for attending. And please feedback anything to us confidentially, or we would like brickbats as well as any accolades. So please, comments. This is a learning curve, and we'd like to know what you'd like next. Thanks, one and all. So we'll.